Hi, this is Kirk, the bariatric carnivore. Or why doesn't your doctor talk to you about lifestyle? And why not, what type of dietary changes that you can make that would actually improve your health? Well, it really starts back about 1911 with the Flexner Commission. And this was the first attempt to standardize medical training, basically in the Johns Hopkins model. And the commission suggested that we need to silo the way we do medicine so that there'd be more specialists. So we'd have heart specialists and kidney specialists, cancer specialists, etc. Because before then, it used to be that you'd have a doctor and he was your doctor. And if you had cancer, appendicitis, tonsils, whatever, they took care of everything. And back then, clinical experience was kind of everything. People really venerated older doctors because they had seen such a wide variety of different patients and they had a lot more experience and they could handle a whole host of different areas because they were either delivering babies, taking care of appendices, or cancers, etc. So they were handling a lot of different things and they had a lot of knowledge in a whole host of different areas. And because of that, they were very good at giving lifestyle advice when it came to diet, exercise, etc., because they saw patients from basically cradle to grave and they knew what worked well to help try to keep people healthy. But when the Flexner Commission came in and people started getting broken up into different specialties, that knowledge was lost. And what has happened during the last century is more and more medicine has been changed from that of holistic ideas of the people and experience and clinical experience being brought to bear to basically where we are now, which is basically a collection of algorithms and symptom management. And you're presenting with a cholesterol of this, you need this drug. That's kind of where medicine is now. It's not holistic. And part of the reason why this has happened was the person that really pushed the Flexner Commission, who was a fellow by the name of John D. Rockefeller, who owned Standard Oil. And what he realized is that there was a lot more money, not just in petroleum products, which was at that time pretty much just a lubricant for industrial machinery. It was also could be used to create pharmaceuticals, but in order to sell pharmaceuticals, he needed to have doctors that would prescribe pharmaceuticals. And he realized that the way that, with this holistic approach, they weren't going to sell very many drugs. So by creating the siloed system where, basically he was creating a system that, and it was a brilliant vision for him, where doctors were basically getting into a position where all they could really prescribe were surgeries, procedures, or drugs. And that's where medicine has evolved. There's no longer an holistic approach. The next major thing that kind of came in to change the practice of medicine was in 1947 when they started doing double-blind randomized trials, and that became kind of the gold standard. Now, it is a great tool. I mean, the double-blind idea had been around since the 1800s when some guy was trying to prove that a particular type of medical practice called homeopathy was nonsense. And he just said, okay, what we're going to do is, one of these is sugar, one of these is the homeopathic remedy, and we'll see who gets better first. And by doing it double blind, he could show that, hey, there's absolutely no difference between the two groups. Therefore, the homeopathy didn't work. And, that was a brilliant test, and they expanded it in 1947 to make it double-blind and randomized, because what they found is that doctors who knew that they were giving the medicine to a particular person asked more questions, etc. And what they wanted to do was to say, okay, look, we're not going to have observer bias in this anymore. By randomizing the patients and making it blind to the doctor so they do not know who's getting the real medicine, who isn't, then we'll have really great test results and want to know what drugs actually work for what disease. And that was really a great tool, but unfortunately, it's kind of like Maslow said. When your only tool is a hammer, you tend to look at all of your problems as nails. And when doctors think that the only thing they've got are double-blind randomized tests to show them what is true or what isn't, you lose clinical experience. It used to be that doctors had a great deal of latitude, and they still do, to use approved drugs off-label. So you've got a drug that is designed to take care of, let's say, worm infestations, and you might figure out that it's also got a great antiviral property, and so you prescribe it for something outside of worms. Okay, that makes sense, because if you've got the clinical experience and the rationale to be able to use it off-label for other purposes. So that is an acceptable medical practice on most stuff, but unfortunately, that's even been called into question. During the last pandemic, people that used ivermectin, for an off-label use were being attacked as saying, hey, you're using a horse dewormer for this type of stuff, even though WHO, the World Health Organization, said ivermectin was one of the most important drugs in the planet. So, and the person who invented it did not get the Nobel Prize in Medicine for creating a horse dewormer. It was a very powerful medication that was used in a whole host of applications. But doctors are being chastised because the Flexner Commission did another thing that was really important. It created the American Medical Association and started creating accreditation boards for medical schools that actually became powerful agents to control the behavior of doctors. And it basically re-siloed them and narrowed down the scope and practice of medicine to cut down on the amount of use of clinical judgment to be able to take care of their patients, but instead really started using it almost as a punitive tool to force conformity of the medical profession and very limit the scope. So as a result, we get some really weird situations where doctors may know that, hey, really good strength training is excellent for preserving good health span and preserving a healthy life and keeping patients mobile for longer periods of their life. But they can't say that because, frankly, any doctor can say, look, there's absolutely no evidence that strength training will prolong your health span and make you stronger and healthier for the long haul. And that flies in the face of common sense, but it is technically true. There isn't any evidence because you cannot do a randomized controlled double-blind study showing weightlifting works better than not weightlifting, because both subjects know who's doing the weightlifting and who isn't. So lifestyle gets kind of pushed by the wayside in how we treat people and medicine, and as a result we get a whole host of different problems. And there's some conditions that are frankly very difficult to study. For instance, anything dealing with hearts or strokes and stuff like that, because even with people that are apt to have a heart attack, you may think this is an overweight chubby person who smokes and drinks, they've got all the risk factors of having a heart attack, but what's their risk of having a heart attack in any given year? Well, actually relatively small. Over a scope of 20 years, yes, their chances are going up, but them personally having a heart attack are relatively low. So what you've got to do is you have to have a group of 10,000, and you're going to have a test of an intervention, and 5,000 of them get the intervention, 5,000 don't, and then you compare the number of heart attacks over 5,000 people, and you create risk assessments. So that's why those big studies are really kind of important because you're looking at large populations, but they don't tell you the whole story and what you need to do individually. We can only look at the large groups and try to make the determination what's the best problem. Now, what this means to you as a patient is you've got to understand the difference between relative risk and absolute risk, and look and try to make your own cost-benefit analysis, because your doctor frankly can't tell you. They've got to follow the algorithm. Here's what the studies say. Well, the absolute risk, let's say for instance, let's try and make this a little more simple than just large numbers. Say I create an umbrella, and this umbrella is going to reduce your risk of being struck by lightning by 95%. Okay, that sounds pretty darn good. Okay, we're going to charge you $500 for this special umbrella that's going to reduce your risk of being hit by lightning. Or you can buy a regular umbrella, but it's not going to reduce your risk of being hit by lightning by 95%. But that umbrella only costs $10. Now you got a question. Do I want to spend $490 extra bucks for this special umbrella that will protect me, give me a 95% less risk of being hit by lightning? Well, ask yourself a question. What are the odds of being hit by lightning? Well, they basically work down to about 1 in a million. So if you have a 1 in a million chance of being struck by lightning, even a 95% reduction risk isn't all that much. I think I might want to save $490 and just get a regular umbrella. But we can make it even a little bit weirder than that. We can say that because we were rushing these out to the market, these umbrellas, these special umbrellas that will reduce your risk of being struck by lightning, they have a tendency to throw off your gait because they're a little bit heavier. And as a result, your chances of stumbling go up about 12%. Now you start looking at, okay, what's the danger of stumbles and falls? And those are actually higher than being struck by lightning. So you're putting yourself at more risk by trying to, and you're spending a lot more money for an umbrella that really doesn't reduce your risk very much. Well, the same thing happens with medications. They tell you that, hey, if you take this, you're going to have a 60% reduction in your chance of stroke. But what are the odds of you having a stroke? And what are the cost of taking the medication in terms of side effects? Like, does it cause excess bleeding? What happens if you have an ulcer in your stomach, which means you're going, and your blood is thinner and you're going to bleed more? Or what about if a vein, you get a head injury and you have a brain bleed, and that's going to have a tougher time stopping because of the drug that you're taking. So you have to look at absolute risk, and what's the cost of the side effects plus the cost of the drugs. I mean, I'm facing that right now. I'm looking at, okay, what are my, they're saying that there's a chance that, when after you've had a blood clot in the lung, your chances of having a future blood clot go up, so you need to be on a blood thinner. Well, the blood thinner costs $600 a month, nearly $7,000 or so a year, which is quite a bit of money. And you've got to take it for the rest of your life, and you have an increased chance of brain bleeds and stomach ulcers and other stuff that could be potentially problematic, though those are relatively low side effects. But what are the chances of having a future blood clot? Well, that's a little tougher to figure out, because they did not, when they did the randomized studies, they didn't look at, okay, what about people who eat low carb that exercise? That wasn't a broken out group. So what are my odds of having that type of damage down the road without any drug. And you try to figure out those numbers to find out what, not the relative risk, not the 60% reduction, but how many people actually got future blood clots. And it wasn't that many. And the number of people that have strokes are just not that high. So why would you, until you understand those numbers, you don't really have the basis to make a very good decision. And therein lies the problem with modern medicine, and trying to get these type of answers from your doctor are darn difficult, because most of them do not read the studies well enough to be able to figure that stuff out either. So it is a learning process for all of us, and you've got to be very careful, because what the pharmaceutical companies will do is they will use relative risk and absolute risk interchangeably depending on what sells their product. They will tell you, yes, your chances of a brain bleed are 1 in 10,000, because they did the study with the 10,000 people, and one person that took the drug got a brain bleed. But they will tell you, but you're going to have a 60% reduction in your chances of having a stroke. But only 2 people had strokes that didn't take the drug. So how much is this really worth? And when you realize that they are always utilizing the best number for them, as far as when they're selling a pharmaceutical to your doctor or to you. Very difficult to figure that type of stuff out. I'm not saying that it's easy, but it is certainly a question you should be asking your doctor, and you need to start figuring this thing out, because we're being sold a lot of stuff, some of it with serious side effects. And we're being told that we have to do it because we're going to be reducing our risk of whatever bad outcome by a relative margin. But what is the absolute risk? And frankly, you're going to have to tease that stuff out, and you're going to have to demand that your doctor show you that type of stuff. And they may or may not be, frankly, capable of doing it, because they don't teach enough on these type of issues, on how to really analyze these type of research papers. Thankfully, we do live in a time when there are people that are doing that type of study. But it gets even weirder than that, because what I've been kind of noticing about blood thinners, because that happens to be a topic on my mind, is that there's certain natural herbs that do have a tendency to thin the blood. Garlic, turmeric, cinnamon can have tremendous blood thinning properties. But they keep saying that there's no evidence that that is going to be the equivalent of these expensive pharmaceuticals. And that is true, because they've never been tested. And because of the lack of testing, anybody can say, we don't have any evidence. And therein lies a problem with all lifestyle interventions. Any doctor can tell you there's no evidence that a carnivore diet is safe. But frankly, the same thing can be said for a vegetarian or vegan diet. There's no evidence that says a vegan diet is safe in the long run either, because we've never really tested them long term, because they're very expensive tests to do. In order to do that one, you can't do double blind. You have to do an interventional trial, which means you have to lock people up in basically a prison called a metabolic ward, so that you can control what they are eating and what they are doing, etc., in a very controlled manner. And because of that, you can only keep people confined for so long before they just revolt, unless they're prisoners. Or the best studies that we've ever done on diet and lifestyle were actually done with conscientious objectors by Ansel Keys back during World War II, and that was a starvation study. And with prisoners, back when you could do those, where people could get time off their prison time if they were just willing to eat a particular diet, and because they were already confined, it was relatively easy to do it. Maybe the best study that's ever been done utilizing people that were in kind of a semi-captive environment was the Minnesota Heart Health Study, which was done back from 67 to 71, where they basically reduced people's cholesterol level by switching their diet from saturated fats to vegetable oils and skim milk and margarine. And yes, they proved that you could reduce somebody's cholesterol level by switching the diet to that low fat, low saturated fat diet. They also proved that when you did that, you killed people. And unfortunately, they buried most of that data until sometime in the 2000s, when it got re-released and reanalyzed, and it showed that it was just how dangerous that was, but that has not been really widely published. Matter of fact, the only reason why I heard about it was because of Malcolm Gladwell's podcast when he was talking about it. And he was talking about it because he was lamenting the loss in the McDonald's French fry that used to be really good because they used to fry it in tallow. Then they switched over to vegetable oil because nobody released the Minnesota Heart Study. That's kind of the unfortunate reality, how difficult it is to get serious data to show you how to live and how to make decisions. And it goes back to what I really think is the only way you really can do it, which is, number one, look at what studies are available and what experts say. Give it a common sense smell test. Does it make sense? If it does make sense to you, what of other people that have been doing it? What type of effects have they had, good or bad? And then try it out on yourself. And if it works, okay, you've now proven something that seems to work for you based on the best evidence that you can. That's about as good as it gets for you. Because frankly, whatever advice you're getting from your doctor isn't going to be good enough, because they can't tell you with certainty, because there's no double-blind studies. The algorithm doesn't give them the answer, and you're going to have to figure it out for yourself, because in this fight for our health, we're all alone. But we can all be alone in this together, and we can work to try to figure out what works best for us. That's the only thing that you got. So this is Kirk, the Bariatric Carnivore. If you like this message, please hit the like and subscribe. Join this channel. The more people like it, the more people join, the more this message gets out, and other people can figure out what might actually work for them. And if you please make comments below. That again helps the algorithm, helps us get this word out to more people. I try to put out a couple messages each week, usually on Tuesdays and Thursdays. I will talk to you again soon.